Hello, everybody, and welcome to the MGUS Smoldering Myeloma chapter. I'm really excited to be with you all today. I'm going to be sharing my screen, to share a couple of announcements as we get started here. So let me make this full screen. So for those of you who don't know, the MGUS Smoldering Myeloma Patients chapter is brought to you by the Myeloma CROWD Community Program by HealthTree. And my name is Audrey Burton-Bethke, and I am the Myeloma CROWD Community Manager. I'm really grateful for your support, your participation in the question and answer session to come later today, and just how exciting it is to be gathered together as a precursor myeloma community, because we're going to take part in critical research that's going to change the myeloma world, and that starts today. So it's exciting to be together. I will introduce her formally in just a moment, but we are joined today by Dr. Irene Ghobrial. Dr. Ghobrial is the first speaker I ever heard talk about myeloma in general. So I'm a big fan. Her clear presentation and insightful observations have really inspired me. I'm really grateful she's joining us today and that you have the privilege of listening to her. And as I said, I'll introduce her formally in just a moment. First, I'd like to thank our sponsors, Bristol Myers Squibb, Amgen Oncology, AbbVie, Genentech, Karyopharm Therapeutics, Oncopeptides, Adaptive Biotechnologies, and Takeda Oncology. So I wanted to talk about why we chose the PCROWD study, a game changer for those with myeloma, as our topic. Full disclosure, we're going to be talking about another study as well called the PROMISE study. So why did we want to talk about these? When considering topics for the MGUS Smoldering Myeloma chapter, I knew I wanted to highlight the critical research that I mentioned earlier that precursor myeloma patients can contribute to. I've talked to many who are frustrated by their doctor's diagnosis of MGUS, and the advice is to watch and wait. Same with smoldering myeloma. And there's more that we can be doing, and there's more that I believe we should be doing. And so while some people are happy about the watch and wait diagnosis, I think it's important that we see what's out there that we can do in order to make this easier for the next generation to come and easier for us in the future. So when the PROMISE study team from the Dana-Farber Cancer Institute reached out to us and asked us to speak, I was incredibly excited that the stars had aligned and we had the perfect opportunity to launch our chapter and spread the word about these amazing studies and this important information. And then when I heard that Dr. Ghobrial was willing to speak to us, I was even more excited. So let me introduce her formally. Dr. Irene Ghobrial is a professor at the Dana-Farber Cancer Institute, Harvard Medical School, and an associate member of the Broad Institute. She is the director of the Michelle and Stephen Kirsch Laboratory and co-director of the Center for the Prevention of Progression at DFCI. Additionally, she is the co-leader of the Blood Cancer Research Partnership, a consortium for innovative clinical trials of community oncology sites coordinated by DFCI. Dr. Ghobrial's research focuses on understanding mechanisms of tumor progression from early precursor conditions such as monoclonal gammopathy of undetermined significance, or MGUS, and smoldering disease to symptomatic multiple myeloma and Waldenstrom macroglobulinemia. She specifically focuses on the role of malignant bone marrow niche in regulating disease progression. She is interested in the development of new molecular and genomic markers that predict progression in precursor conditions, which can identify patients who should be eligible for therapeutic interventions to prevent progression or potentially cure the disease at the early stages before clonal evolution occurs. She has authored or co-authored more than 250 publications and book chapters. She has received multiple awards, including membership in the American Society of Clinical Investigation, the Robert A. Kyle Award, which, by the way, he's the one that named MGUS, in case you don't know, for research in Waldenstrom macroglobulinemia, and the Mentor of the Year Award at DFCI in 2014. Dr. Ghobrial completed her hematology oncology subspecialty training at the Mayo Clinic College of Medicine in Rochester, Minnesota, and internal medicine training at Wayne State University in Detroit, Michigan, and she earned her medical degree from the Cairo School of Medicine in Egypt. So that was a super long intro, but I wanted you to know how awesome she is. So Dr. Ghobrial, the time is now yours.
Well, thank you, Audrey. That's a lot of pressure after all of this, but I hope that I know it's hard with Zoom calls that we all get to see each other and talk. What I'll try to do is maybe present a little bit our ideas of how we can prevent progression, and hopefully no one will be diagnosed with myeloma ever in the future. And then I'd love to actually keep it open more for discussions and questions and what people want to do. So hopefully that will help everyone get to know what we're doing and what we would love to go forward to do. And you'll see that every single study, every single question we ask cannot be done unless the patient is part of this, unless you guys empower us and make us do it. So it's really your work. I speak very fast and I have an accent, so I'll try my best that everyone understands me. Can you see my slides, first of all? Okay, yes. Good. So let me just make sure I can get it into presentation mode. Okay. So I'll take you first to the first question. What is MGUS and Smoldering and why would we care? And I would tell you that every patient to date, if they are diagnosed with active myeloma, if you went and saw your doctor because you have a bone lesion or you had anemia and your doctor said, well, you have multiple myeloma, you probably have had an earlier precursor condition, an earlier MGUS or smoldering myeloma, and it was not diagnosed because you were not symptomatic. You did not have bone pain, you did not have anemia, but for at least 10 or 15 years or even longer, you had that monoclonal protein and those cancer cells slowly growing in your body, and they were not diagnosed. So what if we reverse this? What if we can diagnose you earlier, make a difference in early intervention, and never get you to know that you have myeloma after the fact, after you get symptoms? And if you think about it, MGUS, monoclonal gammopathy of undetermined significance, big long name, which was actually coined by Dr. Bob Kyle, and I trained with him at Mayo Clinic, so I've been very fortunate, is a very common disease. And in fact, he discovered that by screening the whole population in Olmsted County, Minnesota, trying to see how many people have this MGUS. And it was 3% of the population over the age of 50. Now we know that the number is much higher. So think about it. That's many of us walking around as we get older, have this tiny protein in their blood, which is basically antibodies that we secrete coming from plasma cells, which are mature B cells in your body. And they indicate that you already have something that can have the option of going to myeloma. It's still benign, it's not malignant, but it has the ability to go to myeloma. And that's why it's undetermined significance, although we know its significance. And it's a lot of people. Over the age of 50, many of us will be walking around with this MGUS. And in fact, it can be diagnosed at age 40 and younger, and it can occur at a much younger age in African Americans and in certain ethnicities. So that's 12, 14 million people walking around the street with MGUS. Many of us are not diagnosed. Now, if the numbers increase a little bit, the antibody number increases in your blood, or the cancer cells increase in your bone marrow to 10%, and that's a completely arbitrary number, so I'm hoping that that will change someday, then you have something else called smoldering multiple myeloma. And by definition, smoldering is that it's almost on fire. So it's now ready to go to myeloma at a 10% chance per year. So MGUS is only 1% chance per year, meaning 99% chance you won't develop myeloma. Once you get into smoldering, now your chances are much higher, 10% per year. And I can tell you, I see people who are 20, 30 years old. And if you have smoldering myeloma, you go like, well, will I develop myeloma when I'm in 50 or when I'm 60 years old? My chances are extremely high because the numbers increase. 50% chance in 5 years. Now, if your numbers are even higher than that, or if you have something called high-risk smoldering myeloma, meaning your M spike is high, your light chains are high, you have bad cytogenetics, that increases your chance of 50% in 2 years. And those are the people that I tell them, let's talk about probably doing something now to prevent progression. And I'll talk about all of that in a second. So the first thing I wanted to say is, well, can we do something about that? And if you think about it, about any other cancer, we go to our primary care doctors. And if you are a woman, you'll get mammography. If you're a man, you're going to get PSA checked, or if all of us, as we get older, we get colonoscopy. That's called cancer screening. And cancer screening saves lives because you can detect it early And if you detect it early, you can make a difference in survival. And for example, a breast cancer, we will detect it by a mammography. And if you have a small lesion in your breast, no one will tell you, well, you're asymptomatic, you're doing well, why don't you sit on it? Wait until you have metastasis everywhere, lesions and anemia and fractures, and then I'll treat you. You will think that we're crazy. Yet that's what we do every day for myeloma. We don't screen for it, although it's a simple blood test, and I can tell you that a blood test is much easier to use than getting a mammography or getting a colonoscopy. And when we find it, even if when it's very high, we tell people, well, wait until you have anemia, renal failure, fractures in your bones, or high calcium, what we call the CRAB criteria, and then I treat you. Well, that doesn't make any sense. Why would you wait until you have that much disease and then you treat someone? Why can't we define who will truly progress to myeloma, and we treat those people early so that we're not over-treating or under-treating certain people? We don't want to treat everyone, 12 million people. We want to treat only the people who are likely to progress in a couple of years to myeloma and make sure they never develop active myeloma. No one should be developing myeloma while we're watching them. Everyone should hopefully be treated earlier and prevent fractures. So because of that idea, we actually started a whole clinic here at Dana-Farber called the Center for Prevention of Progression, meaning we only look at pre-malignant conditions. So I stopped seeing active myeloma and I only see MGUS and smoldering myeloma. And that's what I specialize in. I would talk to you about what is MGUS, what's your risk of progression, what is smoldering myeloma, can I predict better for you who would progress, and can I offer you treatment in a much better way than the standard of care. And we do all of that, not only at the clinical level, we can take your samples and do deeper sequencing, all of the fancier things to give you a better answer. And the nice thing about our clinic is we can also do virtual consults, so we're happy to see you wherever you are, wherever you live. Hopefully that can help you in getting access to us. Now, part of this clinic was saying, we don't want everyone to have to come to Dana-Farber. We want to spread the wealth to everyone. We want to be part of a community engagement study. And we created something called the PCROWD study. And that's really the study that we're going to talk about. And the PCROWD study was direct to patient access. You have the right to be part of a research study wherever you are. You don't need a physician in between you and us and your care and your research. So you can sign the consent online. You don't need the physician to co-sign it. And you can send us your blood samples as well as send us a signature to say, are you okay that we access your medical records, so that we can take a look at how many people have MGUS or smoldering myeloma, ask them for a blood sample, or if you're getting a bone marrow sample for any reason clinically, give us a little bit of it. And then we can track both clinically what's happening with you, but also genomically, and I'll talk about that, and immune cells, and really create this whole infrastructure so that we can give it back to you. So I can tell you, by the way, yes, you have smoldering myeloma, but I found that you have this good genetic abnormality and this immune cell, and by doing that, I can tell you that your risk is much lower than someone else. So we can give you a better risk stratification for your own disease. And then we also offer clinical trials, believe it or not, for many people, either in the early stages, so prevention, or in the late stages when it's almost myeloma, much more advanced clinical trials. And I can mention those later on. And then after all of this, I'll talk about something called the PROMISE study. And the PROMISE study is really a question of, if we can look for it early, can we screen for it? Can we start identifying people early instead of being found incidentally because your doctor felt like checking in SPEP? So what is the PCROWD study? So that's our basically first study. It was truly to be the infrastructure, to be the basis of, let's have everyone be part of this. It's a community study. You don't have to come to Dana-Farber. You can live in California and give us your sample and be part of the study. So you have to be over 18. You have to have a precursor hematological malignancy, like a blood cancer, an early precursor blood cancer. If you have already myeloma, you don't qualify for it. We're looking for people who have not developed myeloma yet. You can give us your sample anywhere. We access your medical records if you give us the consent, and then we follow up. And we are actually going to launch an app soon where you can have this app on your phone, and then we update you with results. We update you with new trials. We update you with information. Hopefully we will have a wearable where people can say, I'm doing an exercise study, let's be part of it. So there will be a lot of this communication with you throughout that part. This is our website, PCROWD study. Again, you're welcome to look it up right now. Look at all the information about it, and you can sign up. If you have MGUS and smoldering myeloma, please sign up while I'm talking. If you're interested, it's very simple. You just click on a few things, give us your information, and we send you back a kit at home, and you can get drawn whenever you're going to your doctor. So this is the whole idea, is that you get the kit at home, and then you're going to your doctor next month or the month after, you just take that kit with you and you get your blood drawn. And then we track. We have people who have been on this for 5 years and who have given us so many samples. We call the PCROWDers like the best team here, who are always communicating with us. We have a Facebook page, so you're welcome to be part of all of those discussions. This is the kit that you will get. So just to see that it has basically 3 tubes. That's all we ask for the blood sample, and you can get it drawn, and basically it gets wrapped, and we have our FedEx number on it, and that's all you have to do. So this is just information pieces for everyone, that we pay for it. You don't have to worry about anything. You'll get it in the mail, and we will tell you or tell anyone who's doing for you the phlebotomy how to wrap it and how to send it back to us. Now, what do we do with that? I can tell you we have 3,000 people who have joined us so far. We would love to get to higher. I'm hoping we get to 10,000 if we can. It's nationwide right now, although we are looking forward to opening international sites. And we take those blood and bone marrow samples and we ask several questions. We want to identify for you what causes progression and how can we give you that information so that we can stratify things in a better way. And I usually say it's like being the Weather Channel person. If I sit here and tell you there might be a hurricane that can happen in the next 2 weeks and maybe it will hit Florida, maybe not, that's not going to help you plan. But if I tell you I'm a more precise Weather Channel person, there will be a hurricane at the afternoon Saturday and it will hit Miami only, then you are sure that I'm giving you more precision in my interpretation of what will happen in the future. I can never be 100% sure, but I am more and more certain by giving you more information. And that's what we empower you with. You give us samples, we give you back empowerment of what it means. So the first one, for example, is the cancer cells that you have in your bone marrow and in your blood. We're now able to get it in the blood samples. We looked at them by something called next generation sequencing, which we can look at all small pieces of the DNA. We don't have to look at the big pieces like the cytogenetics and FISH that you get clinically. And we found that there were 3 markers that can tell us in much more precision who will progress to myeloma and who will not. MYC alterations, MAP kinase mutation, KRAS, NRAS, and BRAF, and something called DNA repair mutations, P53, 17p deletion, and all of those related to it. So now I can actually sit down with someone, give them that information, and tell them that their survival will be a much longer survival, or let's actually think about treatment early because you will likely go on to myeloma much faster. And we're hoping actually within this year, if we develop it fast enough, we will be able to give back that data to you. We are working on it being research level that's given back to you or CLIA level given back to you. Because the last thing I want is I do next generation sequencing. I know the information, but I cannot give it to you. Right now, it's still research level. I'm hoping very soon I give you that. And that information will guide you whether you want to be treated soon or not, whether you want to go on a certain therapy or not. If you have the 17p deletion, you may want to say, I don't think lenalidomide and dex alone is enough. Let me think of something stronger. So I guide you based on this genomic data to help you make that decision. Another thing that we're working on is liquid biopsies, that we take everything from your blood and we don't have to go to the bone marrow. We can find something called circulating free DNA, which is basically pieces of your DNA that's shed when the cancer cells die. We can find the actual cells, circulating tumor cells, and we can tell as they go up that indeed they can predict progression. We also look at something called the immune system. We know that your cancer cells don't live alone. They live within your immune system. And we know that if your immune system is strong enough, it can prevent progression. And we want to understand that. So we actually take all of your cells from the bone marrow, and now we're doing it in the blood. And we can actually see, do you have enough T cells? Do you have enough B cells? Do you have enough of those other immune cells? And what is their signature to predict who will progress and who will not? But also, can I use it to develop immune therapy for you so that I can develop for you something special cancer vaccines, immunotherapy, antibodies, all of this is coming along in the future. Now I'll move on just to the next step, which was the screening study or the PROMISE study. And the whole idea from that was, well, we're seeing those people incidentally, meaning if you had MGUS, it's purely because your doctor decided to check an M spike on you because you had a little bit of a high protein level or some slight anemia. And why do we leave things for chance? Why can't we just screen people who are at risk of developing myeloma? Not the whole population, but people at risk, meaning if you have a relative with multiple myeloma or any blood cancer, you're at risk. Or if you are of African descent, or if you're Black American, you're at risk because your numbers are much higher than that 3% of the population. Now you have 2 to 3 times higher chance of developing it. And we expected to screen actually 50,000 people. And of those we expected 3,000 people, we actually found that our prevalence was much higher. So now we're only screening 30,000 people for 3,000 positive cases. And then we follow everyone who is diagnosed with MGUS and smoldering to ask the same questions of PCROWD. What is the risk of progression? So again, PCROWD and PROMISE are sister studies. They both answer the same question. If you already know you have MGUS, you go on PCROWD. If you don't know if you have MGUS or smoldering myeloma, you want to screen for it, you go on PROMISE. But they're doing the exact same studies at the end. This is our website, thepromisestudy.org. Again, if you're interested, if your brother, sister, family members are here, please ask them to join. Our criteria is that, and this is just showing you some of the brochures we have, and you can see the QR code. So for all of you, if you can just put your phone on it, all of us now know how to use the QR code. You can actually look up the QR code and you can see if you're eligible or not. Again, if you're age 40 to 75 and you have a first degree relative with blood cancer, or if you are of African descent or African American, or if you have a very strong family history, meaning 2 members with blood cancers in your family, it could be age 18 or above. And we allow first and second degree relatives. So we open it up more to allow many more people to be part of it. And this is just a huge study that we're trying to look up how to prevent progression. So again, this is just the information. So what happens? You sign up online. Again, you sign on your own. We don't need a physician. We send you a kit. This time you take it to Quest Diagnostics because they can take it into 2 different parts. One part goes to Mayo Clinic, where they do for you the serum protein electrophoresis. And we also do mass spectrometry, which is a much more sensitive test to detect the protein, much, much more sensitive than SPEP. And then the other part comes to us as research. And if you are positive, we will call you and tell you about it. Now, I can just tell you, it's been an amazing journey for us for the last 2.5 years. We have, 9 siblings who joined at the same time. We had a person who was in Alaska, and the kit had to be sent over 3 times just to make sure that we get it there. And we have so many people who are really interested. We have twins. So it's been just a wonderful journey to get to know everyone who's part of this community. So again, hopefully we will encourage everyone to be part of this. We have one of the largest number of African Americans on our study, and we've been really working hard to make sure that we engage the community, that we gain their trust, that we really work with everyone to explain what is this and why is it important to screen on this study. In the old days, we used to do things on the ground pre-COVID. Now, most of it is virtual, as you can see now. And just this is showing you some of the work that we had done before, the Jimmy Fund Telethon. We used to send flyers, brochures. You'll see a lot of emails, social media, Facebook, Twitter, Instagram. You'll find us everywhere. We've done interviews with Tom Brokaw, of course, Dr. Kyle, who's just an amazing mentor. And we've been on the news, Katie Kirk and all of those, just trying to tell everyone, you have this opportunity to screen for it. It's a simple blood test. If you're interested, please join us. And this is just some of our community work when we were able to go on the ground. And this is our Massachusetts representative, Ayanna Presley. And then again, some of the church events that we were doing. So I'll skip all of this part and just show you just the kits. This is the kits you're gonna get. So you get red that goes to Mayo Clinic, blue that comes back to us. And basically, if you are positive, and this is the screen that you see. So you begin a questionnaire, you give us a family questionnaire, and then you answer some questions about your history, medications, comorbidities, other medical issues that you've had. If you're negative, we email you telling you that you're negative, and we ask you to rescreen again in 3 years. And if you're positive, we call you personally. I call people or my physician assistant, and we tell you what's going on. And we not only inform you where to go, we also sometimes see you in my clinic. So we want to make sure that we're holding everyone basically with like a white glove experience. We take care of you throughout the journey. We don't just diagnose you and leave you alone. This is just some of our information on social media. And I'll stop here and say, again, this is a study for you and from you. This is not, we would not be able to do any of this work or any of those numbers unless we really had excitement, enthusiasm, and collaboration from every single patient. And the feeling that you are contributing to it and you can make a difference to change your own risk stratification, your own factors. I did not touch about it on the clinical trials, but we have a lot of trials available if you are early in the MGUS and smoldering, if you are in the high risk smoldering, and I go through all of the options and give you what is available and what is available not only here at Dana-Farber, but also in other places. So I'll stop here. I did say that I speak very fast, but I'm happy to answer any questions. Thank you.
No, it's great. And we already have some questions rolling in. So if you have a question for Dr. Ghobrial, please make sure to go to the bottom of your screen where it says Q&A, type in your questions so that we can get those answered. I'm just fascinated at how many people have been excited to contribute already. And I am really hopeful that, again, like you said, we can get that goal of 10,000, because what great data, what accurate and great data that would give us if we could reach that. I'll start with some questions, and then I have some questions of my own as well. So you answered this question, are there any clinical trials for MGUS? And I think it's important, we talk about, okay, yeah, maybe treatment is needed for high risk myeloma, but what is available for MGUS?
Yeah, so it depends. Not MGUS is all the same. So the first thing is, if you have MGUS, sign up to PCROWD, because we're hoping that that spectrum from MGUS to smoldering, we can differentiate it a little bit more. If you are the very, very early MGUS, the almost benign, you may not need anything therapeutic, but we are doing the genomics. We're doing the immune cells. We know that your immune system is not completely normal, even at MGUS. We already did that. So now with the COVID vaccination and with the COVID era, we said, well, what if an MGUS patient gets the vaccine? Will they have a long response or not, a sustained immune response? So we launched a study called the IMPACT study on top of PCROWD. So if you're a PCROWDer, you can sign up to IMPACT. And if you're on IMPACT, we do for you the COVID antibody through Quest. So they gave it to us for free. We also do for you immune single cell sequencing, and we measure your antibody level in a much more sensitive way. That's already a study. It's not a therapeutic study, but it's a study. We are going to launch soon an exercise and fitness study. We have a metformin study. This is a pill drug that can prevent progression. It's a diabetes drug, and we launched it for high-risk MGUS, so a little bit later in the staging. So already there are lots of things that you can do. We're working on a bone health study, because we know that even in MGUS, you may have osteoporosis, you may have bone loss. So why not give you a prevention for bone loss even at MGUS? So the more people are part of this study, the more you'll be able to get that. And my hope is, once we launch the app soon, you'll go like, well, I have MGUS and here are my records and here's my data, but it pops out to say, if you're interested, there is a metformin study. Are you interested? If you're interested, there is an exercise study. So you'll always be aware of what's available, and this will be your way of communicating with us.
Oh, that's so exciting. That's great. That's awesome. All right. So let's see, there's just, I'm getting better at moderating all of the questions. I'm grateful for all of the questions. So they just wanted to make sure, once the kit is sent to them, they go to Quest Diagnostics. Is there any other labs that can take it, or is it just Quest Diagnostics?
So again, let me differentiate them. PCROWD from PROMISE. PCROWD, if you have MGUS or smoldering myeloma, you get your kit, go to your doctor. You're going already to see them to get your blood drawn. The phlebotomist has something in your arm. Just have them draw those extra tubes and they get shipped. For PROMISE, because we don't know that you may have an appointment with your doctor. You're a healthy individual. We have it set up with Quest right now. I am trying to change it because it's too much for people to go to Quest. Although we're now giving a $50 incentive just to ask people to take time off from their day to go drive at Quest. So if you want to be part of this, there's a $50 incentive to compensate for your time. But we're hopefully soon either having the phlebotomist come to you. Quest has that service called Exam One, or we will send you the kit that you can go anywhere you want. You have your local doctor can do that. You're here at Dana-Farber, or you're here seeing a primary care doctor, might as well get it at the same time. So we'll open up the options to allow people to get anything they want.
Awesome. That's great to have that flexibility. How does lifestyle, in your opinion, how does lifestyle affect the progression of MGUS? What have you seen in your clinic?
Yeah, you know, it's hard to know. That's why we want to do the studies. People come and tell me, I'm taking curcumin, I'm taking metformin, I'm doing green tea, I'm doing exercise. All of these are great things. Catherine Marinak, our population scientist who is part of the team, has created the epidemiology survey for all of those questions for us to understand, does obesity matter? Does exercise matter? And how can we modify this to help prevent progression? So we have data and we need more data, and then we need to see also how we can improve on it.
Yeah, I love that. And I know that there's, you know, you were mentioning those studies are going to come out, those fitness, there's nutrition studies going around too. And this is, I just want the patients and the family members of the patients to know that these specialists really do care about you, and they are doing all that they can, but they need your help to contribute to these studies and to contribute to the research in order to find these answers. So I agree with what you said. Let's talk about the results. Okay. I actually don't know what questions I can ask because I am pretty new to this. But we do have a question about, can you talk about the results that you're seeing from the ASCENT trial for the high-risk smoldering myeloma?
Yeah, so the ASCENT trial is not my trial, so I cannot give more details about that. Dr. Shaji Kumar can give more details, and hopefully in ASH we will get more data. But this is one of the trials of high-risk smoldering myeloma where you get daratumumab, carfilzomib, lenalidomide, and dex. So 4 drugs to see if we should treat you just like active myeloma, basically a little bit earlier, and see if we can improve on progression. We just opened here something similar, but without the carfilzomib, with Velcade. So it's Dara RVD instead of Dara KRD. And that one, we just accrued 17 patients within a few weeks. Everyone is excited about it. So again, if you're interested, that could be another study available that I know more information about, just because it's here that I know.
Right. So comment on deciding to join a clinical trial. Who should, like, what are the factors in considering whether or not you should join a clinical trial?
Yeah, great question. Lots and lots of options. And I would say talk to a specialist. That's very important more than anything else. I've seen people who are diagnosed with smoldering myeloma and then their doctor says, well, just get Revlimid and Dex. And I would say, no, let's hold off here one second. Not all smoldering is the same. Not everyone should be treated the same way. You have one thing that's amazing is that you have the time to look at things and look at the data and get a specialist to help you. Smoldering myeloma, there is the high risk, there is the intermediate and low risk. And within high risk, we don't all agree on all the factors. So there is something called 20-20, 20% plasma cells, 2 grams M-spike, 20 light chain ratio. But within that, there is my M-spike is increasing every time I see you, or my light chains are increasing, or I have a 17p deletion, I have a 414. All of this tells me whether you're really high risk or you're not high risk and your number is just 20%, but it's not really high risk. Let's wait a little bit. Let's look at 3 more months and decide. And if you're really high risk, I'm careful not to consider someone for Revlimid and Dex alone. So I'm not a big proponent of standard of care. Let's just treat everyone the same way. Why not go on a trial where you can answer the question and make a difference, not only for yourself, but also for others, to change the future of smoldering myeloma. And we can only change it by, what I hope for is, we profile you correctly and we give you the right approach and the right treatment. Not all smoldering myeloma is the same. Not all myeloma is the same, and we should not be treating them the same way.
Yeah, I've heard it's called myeloma for a reason. It's not your loma, it's myeloma.
Oh, yeah, that's a great one. That's a really good one.
I didn't come up with it, but it's fun to hear. So we get this question quite a bit, and I'd like you to speak to it. When you say go see a specialist, how can they navigate not wanting to offend their current treating physician?
Yeah, I think it's not an offense to any doctor, hopefully never to any doctor, to say, I want a second opinion. It's your right. And we all appreciate each other, and we all, want people to have different opinions and make a decision. I can understand it can be confusing if you have 5 doctors telling you the different things. You'll have to make a decision at the end who you follow. So hopefully that becomes not too much. But the hope is that you're not just seeing and not just as in just. You're not seeing someone who doesn't really know myeloma well, or even smoldering myeloma, that's even a subspecialty. And then they give you advice, and that may not be the best advice for you. And I usually say, if your plumbing is not working at home, you call a specialist, and you usually look through who has good ratings, who doesn't, who has, your neighbors have found good. You don't just say, well, whatever, I'll just get the electrician, they'll figure it out. Don't do that's your own body. So spend the time, investigate it, get an advocate with you. And if you don't have your own personal advocate, I think this is where HealthTree helps. You can go and ask. So HealthTree helps you in that a lot. People who have the expertise help you. The foundations like the International Myeloma Foundation, the Multiple Myeloma Research Foundations, all of them have information for you to know who knows this area, who specializes in it.
Yeah, exactly. And I would just counsel, there's no need to be afraid, and you don't even need to tell your treating physician that you're going to get a different opinion. There's no law that says you need to consult with your doctor before seeking a second opinion. And also, in regards to these studies, I think it's exciting to share with your doctor that you're going to take part in these studies, and that's in no way going outside for different I don't know what I'm trying to say, but this is an exciting thing to share instead of being nervous about looking outside of your local clinic. Um, so here's one that received the results from his antibody test from Quest, but there were so many disclaimers that he couldn't tell if he had gotten protection or not from the vaccine. So how can he get a better interpretation of the results that were given to him?
Yeah, it's a great question, and we get it almost every day. We don't know well yet if the antibody level, what's the antibody level that's protective? How long will that be? It's not only the antibody that matters, but also your immune cells, the actual cells that matter. So that's why we're doing the impact study, so that we can answer the questions correctly rather than, trying to predict what will happen. So we're doing antibody testing plus all the cells at the same time. And we will release this data as soon as we get it done. It's not going to be in person, although I'm trying to see if we can get the IRB to give us the in-person data. But we will say, here's 700. So we have 700 people who signed up for MGUS and Smoldering, and we're working now with MMRF to get another 500 who have active myeloma through PCROWD. So we will screen all of this for all of this sequencing and then release all the information as soon as we get it.
Great, that's exciting. Could you talk about the relationship between MGUS and peripheral neuropathy?
Yeah, great question. So once I see someone who has MGUS and they have neuropathy, I start looking for several things to make sure I get them checked that they're not in the system. One is something called amyloidosis. It's a cousin of MGUS, but the light chains, the piece of the antibody that you secrete, is a sticky protein, and it likes to go and stick to your nerves or to your kidneys or to your heart. It's important to make sure you don't have amyloidosis because it's a completely different track, completely different system. We also look for other things, antibodies that can attack the nerves, or something called POEMS, POEMS. So we start looking at different things. Sometimes we never find the cause, so it's still MGUS with neuropathy. And sometimes if it's really bad, we start thinking, should we treat you to prevent further worsening of the symptoms? Again, it's important, and this is where what we call MGRS or MG, monoclonal gammopathy of known significance or of neuropathy and then of renal significance. But MGUS is not always benign.
Okay, that's great to know. I've heard that a lot. I have MGUS, but I have symptoms as well. So what's going on? I've seen a lot of questions. They're asking how often should they be monitored? You know, it's watch and wait, but some are getting yearly, some are getting monthly. What's the ideal frequency that they should be getting the tests, and what tests should they be administered or should be administered to them?
Yeah, it depends where you are in the disease. If you're very early MGUS, and we've checked it a couple of times over 1 year, so we usually say every 6 months, and it's always stable, and you're early in the disease, we would say once a year is fine. Of course, if you're worried, come every 6 months, and we do blood tests, the SPEP, the serum free light chain, your blood counts, your kidney function, calcium, and all of that. We're now doing mass spectrometry to get a much more sensitive testing, and of course, we do all the other research testing. If you have smoldering myeloma, this is when we, of course, say, well, maybe we should consider a bone marrow biopsy. Even in some MGUS, we say, let's consider a bone marrow biopsy to see where you are. We consider also imaging, meaning CT scan or MRI or PET CT scan. I think X-rays are, not that important. Skeletal surveys should not be used. And then we start doing it more frequently, every 3 months, because we want to make sure we don't miss a progression. If, of course, you've been stable for a long time, we start saying, okay, you can come every 6 months instead of every 3 months. And I have people who do virtual visits with me once a year, but they're doing the other visits with another doctor. So this way, they're not always having to see me every time.
Right. I think this is a good cause for being your own best advocate. You know, if you're not being as tested as often as you feel comfortable and you are having those symptoms or whatever, I think that's where you be your own voice and say to your doctor, you know, I am interested in being tested more often. And I mean, it depends on the insurance and stuff too, but just being your own best advocate is so important. We have a question about if they qualify for the PCROWD. She was diagnosed with MGUS 5 years ago, but last 2 blood tests said the spike was undetected. Apparently she still has MGUS. Is she still a candidate?
Yeah, I mean, it's hard to know why it was undetected. It sometimes goes away, which is great. It's rare. Sometimes we need to do mass spectrometry just to make sure we know where it is. I would say sign up on PCROWD, but if you really think it's not there at all, you could sign up to PROMISE if you think that you don't have the disease. Again, both are available for you.
All right, thank you. So let's talk about if they do have MGUS, they do have smoldering, they do progress. Do you not transfer them? Do you, what's that word? Whatever, to another doctor? I guess transfer is a good word. Do you move them to another doctor?
Yeah, so Omar Nadim, who's one of my colleagues, as well as Cliff Mo, we sort of work hand in hand. So if it is an overt myeloma, I usually ask the patient if they're okay to see Dr. Omar Nadim or Cliff Mo, because now we have a lot of other things, other clinical trials, opportunities for CAR-T. Believe it or not, we're thinking of CAR-T and smoldering myeloma too, but lots of other options that you can think of that you need another specialist for that. And this is why it keeps me also focused 100% on how to prevent progression.
All right, thank you. Do you ever prescribe, I know you said you weren't a big fan of the Revlimid combination, but do you ever prescribe lower doses of Revlimid for smoldering myeloma?
I think right now, and again, this is an area where Dr. Rajkumar and I disagree a little bit. I think, if you can go on a clinical trial, because I still don't know who truly is going to have that huge benefit or no benefit from Revlimid and Dex. If you have the opportunity, go on a clinical trial, because then you learn from it and you're watched carefully and you may be able to cross over to another study. If you have very high risk, I would consider treatment of active myeloma rather than giving Rev-Dex alone. And if you have extremely low risk, I may not put you on Rev alone. So I'm a little bit careful. Very few cases that I say, yes, okay to go on Rev-Dex as standard of care, but I'm much more conservative in that area.
Yeah. Let's talk a little bit about, just because we're talking about differing opinions, there have been so many differing opinions lately of multiple myeloma specialists about how to diagnose smoldering myeloma. Where does it start? Where does it end? When does it become active? And there's even been talks of perhaps eliminating the smoldering diagnosis and instead just keeping it MGUS and active. What have you heard, and what's your personal opinion on that?
Yeah, I mean, again, we're all trying to put names on something that should not be in boxes, right? So think about it, your journey with the disease happens by one cell switches around, becomes cancer-like cell. It's not yet cancer, it has the ability to become cancer. And that cell can grow a little bit and then change the immune system around it, and then they grow a little bit more. And throughout that journey, you are the same person. You're not an MGUS, and then suddenly, well, I have 9% cancer cells in the bone marrow, but someone else said it's 11%. Oh my God, I have smoldering myeloma. Forget all the naming. We put names around things, and we give identities to things that don't actually exist. And it's all for us to communicate with each other. But remember, you're the patient at the end of the day. You're not a number, and your bone marrow that's 9% or 11%, it doesn't matter. Your bone marrow that's 55% or 65%, it doesn't matter. We're using numbers for us to help manage the continuous that is the patient. So with that in mind, you have to be careful how you predict. I personally think there is room for all. There is the benign MGUS, the one that may never go on to develop myeloma. There is the one that has already changed a little bit to myeloma, but has not gone all the way to cause problems. Maybe that's what the smoldering is, the definition. And then there is the one that is really bad, but may have not caused the damage. Let's call that active myeloma. So there is room for everything. We just need to redefine and be more careful in how we're defining all of those, so that we can also intervene at the right areas. And the only problem now is we're using clinical markers that are not very good in predicting what's going on in the body.
Right. Yeah, I thought you would have a good perspective on that as someone that specializes in precursor myeloma. So thank you. Has there been have there been studies demonstrating that early smoldering intervention results in longer overall survival compared to patients who begin treatment when they progress to multiple myeloma?
Yeah, great question. And that's the big controversy, right? If we knew that for sure, 100%, everyone would be treating early and you'll never wait to active myeloma. But that's why everyone is still having this controversy about it. So you can see 3 doctors, and each of them will give you a completely different opinion. One will say, no, wait, there is no data. One will say, absolutely, start early. And, I would tell you, let's look at the risk. There were 2 studies that have shown that Revlimid and dexamethasone are better than observation. However, they had caveats, both of them, and that's why it's not standard of care yet. The first one was done over 10 years ago in Spain. They treated Revdex versus observation. They showed that it prevents end organ damage, meaning it prevents your bone lesions, your anemia, and it also had an overall survival benefit. So that should be proof of concept that you should be treated early. But because it was done in the very old days, they did not put patients on the right things when, it was done not what we would do right now. People did not think that we should be using it. Then the ECOG study was done by Sagar Lonial and Vince Rajkumar, where they treated Revlimid alone or observation, but they give Revlimid continuous until progression. So that also showed progression-free survival benefit, meaning that you prevent active myeloma from happening, meaning lesions in the bones, renal failure, but it did not change overall survival that we know of. So you could argue, well, let me wait until I have active myeloma and then start the treatment. And because we don't have that answer, everyone who's saying different opinions is probably right, because they're all looking at it from different angles, right? And again, it depends on you, it depends on your comfort, it depends on what you're willing to take as risk and benefit. If you're looking at, can I prevent my own end organ damage, meaning can I prevent fractures, kidney failure? If that's your endpoint, the answer is yes, early treatment prevents it because you will delay it. And hopefully overall survival will also matter, because the longer you be treated and prevent progression, the better. Conceptually, it makes sense that if you treat smaller number of cancer cells with a more active immune system, you would do better than someone who has a lot of disease and a bad immune system. But we need to prove that, and we need all those trials to prove that point. So
Yeah.
very long answer to say, I don't know.
No, it's great. I think it's important that we realize how much is going into this. Talk a little bit, we got a couple of questions as you were talking, talk a little bit about the difference between progression-free survival and overall survival, just one more time, if you could clarify that.
Yeah, at least for the smoldering trials. For other trials, it could be slightly different, but progression-free survival, meaning that when is the time from the start of your treatment to CRAB criteria or myeloma defining events, meaning to kidney damage, bone lesions, anemia, calcium high, 60% plasma cells, and so on, to the time where you're diagnosed with active myeloma. It prevents that from happening. Progression-free survival on other trials is used also by saying you've progressed already and you're requiring the second therapy. Overall survival, meaning your actual survival. We only have two choices. We're alive, we're dead. That's all we have.
That's great. Thank you. There's a couple more people that joined a little bit later. We're glad you're here, but they were wondering if this is available, if these studies are available outside of the US, and if you could talk about what's in the future for these studies.
Yeah, PCROWD, we tried to open it internationally in so many sites, and what we ended up is at each country, they will collect their own samples and then send them to us in collections, because it's very hard to ship samples across countries, as you probably know. There are so many red tape on this. So we have a collaboration with the Greeks. We have a collaboration with the English. We have the Germans. We have a lot of international sites that are working with us to get their own collections. And we send them actually the whole protocol to make sure that they're doing the same thing, and then they send it to us. But it's not online. You cannot go PCROWD UK and then you sign up. I'm hoping we get there. And this becomes like an international effort. PROMISE has just opened in South Africa. We'll open in Kenya. We're hoping to open in Israel. We tried to open in Canada. It was very hard to find someone who wants to take it as the PI and run it through the IRB and get all of that work.
Right.
But we're interested, we're excited to open it everywhere so that this is not just a national study.
Okay, awesome. So as another myeloma precursor disease, is solitary plasmacytoma included in these studies and trials?
Yes, solitary plasmacytoma is included in PCROWD. So you're welcome to sign up to PCROWD too, if you want. It's rare, but we would love to make sure that we follow solitary plasmacytomas.
Great. Is there a liquid biopsy available yet? I know you talked about that. If not, when is it available? And if so, when can they get it? They're really excited.
Yeah, there is one available through the Multiple Myeloma Research Foundation for CureCloud, but it's for active myeloma. We did a collaboration with them, and we said, if you're on PCROWD and you have smoldering myeloma, you can get the liquid biopsy clinical approved through CureCloud. So please, if you have smoldering myeloma and you signed up to PCROWD, look up CureCloud for MMRF and you can sign up to it, and they'll come and draw your blood. And then we're working now on the next level of liquid biopsy.
Awesome. So we talked a little bit about lifestyle with different supplements. Are the patients that are entering these trials allowed to be taking supplements, or do you ask that they refrain from taking supplements during the trials?
Yeah, we ask them to tell us what they're taking so that we can actually be informed, because the last thing I want, and this has happened before, you're taking high doses of a certain vitamin and that actually interacts badly with the drugs. So now the drug is not active anymore because you were trying to protect yourself, but you actually cause more damage. So this is where, tell us about it. It will let you know if we think that may not be the best thing to take right now.
Great. Let's see. Doctors, it's a common, how do I say this? Lots of oncologists and hematologists are saying that myeloma is not hereditary. The PROMISE study is, I think, testing, is it? Is that correct? Or are we looking to see if it is hereditary? What's the end goal of the PROMISE study?
Yeah, so the PROMISE study is saying, this is interesting, a lot of people who have families also have a very high chance of having also myeloma. There must be some factor we inherit that allows this increased susceptibility. So it may not be your typical familial things like BRCA1 and BRCA2 in breast cancer. It may not be a very dominant gene that everyone gets. But when I see, you know, sister, brother, and mom had myeloma, I start thinking there must be some gene that either inherited and we haven't identified, or increase your susceptibility. It could be an immune gene. So it's not a gene that causes cancer. It's a gene that changes your immune system, allowing you to get the cancer. And by having the numbers, 30,000 people, then we can answer the question. The problem is the studies that have been done so far are very small to answer for the, you know, the correct question that way.
Okay. Talk about how often they're tested throughout the studies. So let's start with the PCROWD. How often are they asked to do those blood draws and bone marrow biopsy?
Yeah, if you're MGUS, we ask you once a year, send us your blood sample. If you're going for a bone marrow at any time, tell us and we will send you a kit to give us that precious extra sample, because we know that bone marrows are hard. And if you are coming here, please tell us about it. We will take it personally and carry it to the lab so that it's fresh cells. You know, bone marrows are so hard to do and they're so painful that we want to make sure you never have to go through that. Hopefully in the future, we will always get blood only. If you're smoldering myeloma and you're seeing your doctor every 3 or 6 months, this is when we're asking you to give us your samples at least every 6 months if possible.
Okay, awesome. Why should someone join a clinical trial if they feel good, if they're not sick?
Yeah, so remember, those are trials that are only samples. They're not therapeutic trials. I'm not giving you any treatment in those trials. So if you're feeling great, please join, because I want to learn what's in your system, which cancer cells, which immune cells you have that make you be so good versus someone else. And I go like, if he has those amazing T cells in his body that are protecting him, can I develop a therapy that makes T cells so good like that? Only if I compare people who don't progress to people who progress can I actually find what's different. And then I can come back and say, how can I fix that problem?
Yeah, that makes sense. We have somebody that's being treated for smoldering myeloma at Weill Cornell, and they heard through the grapevine that they might be collaborating soon for the PROMISE study. If so, should they just wait until that collaboration goes through? Or should they just go to the website and sign up?
Sign up anytime you want online. It doesn't matter. And we would always say that you came through New York. So Cornell is wonderful. We love Dr. Niedzwiecki and all of his team. In fact, one of my own instructors just joined the team there. So please sign up anytime. Don't wait. And you know that we will still send you back to Dr. Niedzwiecki and his team.
Okay, awesome. Will any of the results, hypothesis, presumptions be available on that impact study or only after peer review?
Yeah, so there is something called bioRxiv where we show the data immediately. We're now learning that we don't have to wait for papers to be published. We show the data as it comes through, and this is part of our own studies right now. It's rapid release of information back.
Awesome. That's good news. All right. So let's see. It's hard to choose. You guys are asking great questions. All right, so a year ago they had a plasmacytoma and that was removed, and then they had radiation, was anemic, also has translocation 1114, 15% in the bone marrow, since radiation, no longer anemic. Also have the lambda chain, light chain heavy. So the doctors, the treating doctor is like, I don't know what to do with you. I don't know where to put you.
I would say see us virtual consult or anything like that, and we're happy to look at the personal data for patients.
Yeah, it's interesting, huh? Because kind of like what we were saying earlier, myeloma, it's very unique. Even, you know, if you say, oh, I have myeloma and somebody across the street has myeloma, that could look extremely different.
Myeloma is the same.
Yeah, there are a lot of people wondering, what are the symptoms? So when you start to feel symptoms of myeloma, or when you think you might be transitioning from MGUS to smoldering, what might that feel like?
It depends. I mean, hopefully we see it in the blood before people have symptoms, but anemia feels like you're fatigued and tired. Bone pain, you know that very well. Everyone will know bone pain or fractures. Kidney failure will feel also, fatigue, tiredness. People will have, changes in their urine. It becomes a little bit frothy. Hopefully, again, you don't wait for symptoms for this to happen before you start having blood tests and we know what's going on.
Yeah. All right. People are getting confused between the PROMISE study and the PCROWD study. So let's talk about the differences one more time, if you don't mind.
Sure. If you already know you have MGUS and Smoldering, PCROWD. If you don't know that you have any disease, you're healthy and you're screening to see if you have it, then PROMISE.
Awesome. Let's talk about, there's an interesting question that I don't know if you know the answer to. Do different laboratories, could they give different results depending on the same blood sample?
Yeah, I mean, it's hard to think that you're going to send the same blood sample across, but yes, it happens that some levels in one lab could be slightly different than another lab. And we usually tell you your M spike is 2.1 here, but 2.3 here. Doesn't mean you went up. It just means that the labs are slightly different. Let's repeat in the same lab to make sure that we're consistent.
Is it okay to be sedated for a bone marrow biopsy? I know you said they're super painful. What's your suggestion?
Yeah, I started doing conscious sedation for everyone who comes. Why would we go through the pain?
Yeah, that's great. All right, this is an interesting question. And again, I think there's a lot more research that needs to be done. Is there any environmental risk factors identified for MGUS or myeloma?
Yeah, I mean, we know so far pesticides, herbicides, post radiation exposure, hairdressers. There are some things that we know can be associated. Agent Orange, post 9/11. So there are parts. The questionnaire that we have on both PCROWD and PROMISE is the same questionnaire, and we ask you a lot of those questions to see if that can help us identify some more risk factors.
Okay. Do you always go from MGUS to smoldering to active, or can you jump straight from, well, I think you know what I'm saying, but yeah, if it goes from MGUS to, can it go to active myeloma?
Yes, so again, it doesn't read the textbook, usually the disease. So some people, one, they may have been mislabeled as MGUS, but they never had a bone marrow biopsy. So they may have had actually smoldering myeloma throughout. And we know that we published a study on many people who had an M spike above 1.1 gram that actually were smoldering myeloma, but they never did a bone marrow biopsy. So it's hard to know. But in general, the spectrum of the disease is not linear. I cannot draw a line and say, well, your M spike over the last year has been this and this and this, therefore it will always be this. It can change. It can suddenly go up. And that sudden change, we don't know from what. Is it your immune system? Is it that you acquired another mutation? And that's why we say close follow-up is important.
Yeah, that's awesome. Thank you so much for your time. I know you have to go, so I want to be respectful of your time. It's been amazing just gathering together as a community. I think it's really important, just as we've emphasized throughout the meeting. These studies are critical research that's being done in the precursor myeloma field, and we can't do it without participation from you guys. And so I appreciate you being your own best advocates, you guys being here, and Dr. Ghobrial, that was amazing. Thank you so much.
Well, thank you so much. I appreciate it.
Yeah, we're just going to finish out with a couple announcements and then we'll be done. So let me share my screen one more time. Our next session will be in July. I will make sure to contact each of you to let you know when that will be. And we're going to be talking about what clinical trials are out there for high-risk smoldering myeloma patients. These are a list of other events that are going on within the myeloma crowd community that we invite you to. Even if you are in the precursor myeloma stage, being educated about myeloma, active myeloma treatments and things like that is extremely beneficial so that you are more prepared if that day comes. So we have on Wednesday, the Connect with the Myeloma Crowd chapter. We're going to be talking about tracking your key labs on HealthTree Cure Hub. Even now, I'm sure you're a bit overwhelmed with all the different doctor visits, all the labs that you're getting, all the records that you have to keep track of. And here at the HealthTree Foundation, we have created HealthTree Care Hub in order to help you, your myeloma journey go easier, be able to keep track of all of that. Then we have a newly diagnosed myeloma patients chapter on May 20th. It's the frequently asked questions of newly diagnosed patients. How can you become empowered and communicate with your healthcare team effectively? What are the best questions to ask your doctor at diagnosis? There's also other events like Selinexor support, our Selinexor support group, many other events that you can see on the screen. And the link to register for any of those events and even more events that I don't have listed here is www.myelomacrowd.org/events. That will be included in the follow-up email that you will receive along with this recording. Another thank you to our sponsors, Bristol Myers Squibb, Amgen Oncology, Karyopharm Therapeutics, Adaptive Biotechnologies, AbbVie, Genentech, Oncopeptides, and Takeda Oncology. And thank you for joining us today to build a strong myeloma crowd community. We appreciate you, and thank you again, Dr. Ghobrial. We hope that you guys have a great night. Thank you.